I want to start today by sharing with you my screen here. All right, let me start that again with my screen big. I want to start by sharing my screen with you here. I'm just on Google Scholar, which is the academic search engine of Google, and I typed in exercise low back pain and I got 3 million results. 3 million results. And so this is something that's been studied extremely extensively. And yet we still know very little about it. All right, so we're going to talk today about low back pain and sciatica, and in particular, what it is and the natural history, which is what happens if we do nothing. Learning goals for today: low back pain is pain, or LBP is the abbreviation commonly used for low back pain. Low back pain is pain, tension, or stiffness between the rib margin and the gluteal fold, with or without leg pain. Sciatica is leg pain from a nerve root. Low back pain is biopsychosocial. And most low back pain halves in 6 weeks, then halves again in 6 months, then halves again at 12 months, regardless of treatment. 95% of sciatica resolves in 12 months, regardless of treatment. So it possibly is a case, like Voltaire said, of medicine consists in amusing the patient while nature cures the disease. Okay, so low back pain is pain, tension, or stiffness between the rib margin and the gluteal fold, with or without leg pain. So we're going to be reading from the ACSM's guidelines today. And one of the skills I want to help you develop over this program is reading from the ACSM guidelines and making sense of that and applying that to your clients. So please grab out your copy of the ACSM's guidelines. Here's my copy. Flip to the contents, which are on page XX something, XX3. In the contents, go to the second page of the contents, and under Chapter 6, Exercise Prescriptions for Healthy Populations with Special Conditions, second from the top is low back pain. Page 172. Turn to page 172. Low back pain. Okay, so that's what we're going to be reading from. Low back pain is defined as pain, muscle tension, or stiffness localized below the rib margin and above the inferior gluteal folds, with or without leg pain. Okay, so the rib margin, that is literally just where your bottom rib is. So if you feel with your fingers, your thumbs on your back, you can feel where there are ribs. Go a bit lower, eventually you come to a place where there's no ribs. Okay, at the very joint or the very join of where the bottom rib is, and below that there's no rib, like that is your inferior rib margin. Just margin just means edge. Inferior just means lowest. Okay, it's just the bottom edge of your rib cage. That's literally what inferior rib margin means. All right, thumbs up if you found the inferior rib margin. Okay, great. The gluteal fold. can't show you that for two reasons. One is modesty. The second one is my camera doesn't decline that far. But basically, you know, where your butt folds into your leg, right? So feel that on yourself, where that is, okay? The inferior gluteal fold. Here's where it is on this woman, okay? So pain in between there and the rib margin, anything above the gluteal fold and below the rib margin is low back pain. With or without leg pain. So, give me a thumbs up for yes, thumbs down for no. Is this low back pain? Yes, that's low back pain. Is this low back pain? Yes, that is low back pain. Is that low back pain? Yes, that is low back pain. What about this? Yes, that's low back pain. What about that? Yes, that is low back pain. Why is this important? Well, if someone has this symptom, or this symptom, or this symptom, or this symptom, the same guidelines apply because it's all, according to the ACSM's definition, low back pain. Right? So we don't do one thing for a pain here and a different 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 thing for a pain here. It's all low back pain. So the same guidelines apply. All right. I think we're still on page 172, second paragraph. Individuals with low back pain can be classified into one of three broad categories. Low back pain potentially associated with a specific spinal cause, e.g. cancer, fracture, infection, ankylosing spondylitis or Aquinas syndrome. What is the umbrella term that we've used to describe all of those things collectively? Type it into the chat. Serious specific spinal causes of low back pain, aka red flags, correct. Okay, so three categories, all right? So there are only three kinds of low back pain in the world. Low back pain caused by red flags, low back pain potentially associated with radiculopathy or spinal stenosis. Okay, we're going to talk about what that is. And C, non-specific low back pain. Low back pain with no known pathoanatomical cause, which encompasses over 85% of all cases. Okay, what is low back pain? Type it into the chat. Try and do it without looking at the ACSM guide or your notes, because the ACSM guide and your notes already know the definition of low back pain. What we want to do is improve your recall of the definition of low back pain. Okay, see if you can say it with me. Low back pain is defined as pain, muscle tension, or stiffness between the rib margin and the inferior gluteal fold, with or without leg pain. What is acute? Oh, sorry, we actually didn't talk about that, so I'm just going to go through that with you briefly. I'm not sure, maybe I deleted that slide somewhere in the mix. But if we go back to our ACSM guidelines and we look in this second paragraph, on page 172, we can see about halfway down, for prognosis and outcome purposes, low back pain can be described as acute, that's less than 6 weeks duration, subacute, that's 6 to 12 weeks duration, and chronic, more than 12 weeks. Now you should be fully equipped to answer this question. What is acute, subacute, and chronic low back pain? Great. So good answers. A couple of you have said like the varying stages of low back pain. Be more specific, please. So specifically, what is acute, what is subacute, and what is chronic? Jolly good. All right. Acute is up to 6 weeks. Subacute is 6 to 12 weeks, and chronic is 12 weeks or more. What percentage of low back pain is not caused by anything serious? The answer is 85%. Okay, we saw that low back pain is pain, tension or stiffness between the rib margin and the inferior gluteal fold with or without leg pain. Now we're going to think about sciatica. And there's a little bit of anatomy here. So sciatica is leg pain from a nerve root in the low back. Okay, so sciatica is a general name. It's actually not really the scientific name, although it does get used a fair bit in scientific papers. It's just a general name for pain in the hip, so in your butt, in other words, and in this back and the side of the leg and the foot, that is caused by irritation of a spinal nerve root in the lower back. So it's pain that you feel in your butt, your leg and your foot that is not caused by anything in the butt, the leg or the foot, but that is caused by something in the low back, specifically irritation of a nerve root. And just like low back pain, there are 3 kinds of sciatica in the world. One is called referred or radiating pain. The second one is called radicular pain. And the third one is radiculopathy. We're going to look at what each of those are. And in order to do that, we're going to need to think about the anatomy of a nerve root. Okay, so your spinal cord is not a separate structure to your brain. It's actually part of your brain. Your brain is made of the little grey cells, as Hercule Poirot would have it. And the little grey cells are called neurons. A neuron is a nerve cell. And a neuron has 3 major components: a cell body, also called the soma. Soma just means body, like you've heard of people doing somatic things, somatic symptoms, somatic practices, etc. So soma just means body. It's got an axon, which is the tail, and then it's got nerve endings, and the nerve endings are the part that detect chemicals or temperature or pressure or vibration, and then they stimulate the nerve to send a signal up the axon to the cell body. Now these bits here, these are called dendrites. I didn't include these because they're not really relevant. Dendrites. Terrible writing, sorry. Dendrites. And they are the things that connect to other neurons in the brain. So neurons in the brain connect to each other, and the dendrites, these little sort of branching arms and fingers here, are the things that connect to other neurons, whereas the axon, the long tail, is the thing that goes out to where the sensory parts of the nerve are. All right, so that's the base. Those are the basic parts of a nerve cell, and they're very, very small. So if we take that nerve cell body and we compare it to the thinnest human hair that you could see with your naked eye, it's considerably smaller than a human hair. So you can't see nerve cells, they're too small. A nerve, so this might be something like 71/1000ths of a millimetre, something like that, so 7/100ths of a millimetre. So if you imagine I don't know, we're all in different currencies here, but I mean, you guys know how thin a very fine human hair is, right? Well, this is about 20/1000ths of a millimetre. So that is less than 1/3 of the width, or just a little bit less than 1/3 of the width of the finest human hair that you could see if you had perfect 20/20 vision. So that to give you a sense of the scale here. So the neuronal bodies are very, very small, but their axons can be extremely long. And I think this picture is actually pretty good because you have the neuron body here, right, somewhere in the brain, and then you have the axon. Well, if you've got like a sensory receptor in your thigh, right, well, you've got to have an axon that goes all the way down to there to get that information. So these things are unbelievably small in terms of diameter, but they're very, very long. Like some of them can be like a couple of meters long. So depending on how tall you are, obviously. All right, so your spinal cord is the axons, the tails of your brain nerve cells. So you've got this cell body or soma in your brain of, say, a sensory nerve, and its axon goes down your spinal cord. Here is your brain. Well, your brain goes inside here. Your brain goes inside here. And there's this big hole at the base of the skull. And that big hole, anyone know what the name of the big hole is? Anyone know what big hole is in Latin? Foramen magnum. That's what this is called. Foramen means hole, magnum means the biggest, or big. Okay, so it literally is called big hole, okay, in the base of your skull, and that is where your brain, the axons of those neurons, exit into your spinal canal. And directly below that, you have your cervical vertebrae, which have collectively a hole down the middle. That's your spinal canal. And that lines up with the foramen magnum. Okay, so you've got this tube inside your spinal bones where the axons of your brain cells go. So you've got the cell bodies of these neurons in the brain, and the tails, the axons, go down through the foramen magnum, through the spinal canal, down out into your body. So your spinal cord is actually, literally, physically part of your brain. It's not a separate thing. So this is the cross-section of a spinal cord. So this is a very thin slice of a spinal cord. And the scale here is that is about 15 millimeters wide. So that is maybe 5/8 of an inch. Okay, so you could hold that in your hand. You could see that pretty easily. Here is an L4. Okay. There is the spinal canal of the L4. It's about 5/8 of an inch. Okay, so that's the scale on this. This is comprised of axons, right? The tails of those nerve cell bodies. Now remember, the nerve cell body itself is about 1/3 of the thickness of the thinnest human hair you can see with 20/20 vision. So that's the cell body, is 1/3 of that. The axon is a tiny fraction of the width of the cell body. So the axons are unbelievably tiny. And in fact, your spinal cord is made up of hundreds of thousands of axons. All right, so your brain and your spinal cord together are called your CNS, or your central nervous system. And that literally just means your brain and spinal cord. But bear in mind that the brain and the spinal cord are not separate things. They're just kind of different regions of the same structure. The spinal cord runs through the spinal canal, which we looked at before. So there's the vertebral body, there's the spinous process, the transverse process, the superior facet, and here is the spinal canal. And that's the purpose of the spinal canal, is to protect the spinal cord. And inside the spinal canal, there is a fluid called cerebrospinal fluid. And cerebro means your brain, and spinal means your spine. So it's just the fluid that surrounds your brain and spinal cord. So it's the same fluid that's in your brain. And any time in your body that there's a fluid, it's primarily made of water with just some bits floating in it. So cerebrospinal fluid is water with some bits floating in it. And the bits that float in it are the nutrients and the proteins and the immune cells and things that are required to keep that tissue healthy. So it's just water with some proteins and some sugar and some oxygen and some immune cells and things floating in it to keep your brain and spinal cord healthy. And between each pair of vertebrae is what's called a neural foramen. And foramen means gap or hole. And here is the neural foramen. So we have an L4, your second lowest lumbar vertebra. And we have an L5, your lowest lumbar vertebra. I used to be able to focus that. Let me turn it off and on again. Right. So there is your L4, and you can see from the side, in between the inferior facet and the vertebral body, there's this kind of cutaway. And when you look at the L5, in between the superior facet and the vertebral body, there's again a little, much smaller indentation there that is kind of a cutaway. When we put those one on top of the other, those little cutaways form a foramen, a gap, a hole. And that is where the nerves exit the spinal cord and go out to the various different parts of your body. All right. So if we look at it from the top view, there is your spinal cord. That's comprised of hundreds of thousands of axons, each microscopically small. And there is the nerve root exiting the spine through the neural foramen. We have a look at that on the plastic model. You can see there is the L5, there is the L4, there is the neural foramen, and there is the nerve root. And you can see inside the spinal cord, or maybe you can see, inside the spinal canal, there are all of the axons travelling down through that spinal canal. And there's a nerve root that exits between every pair of adjacent vertebrae. Nerve roots exit the spinal cord to innervate, which means to just supply with nerves, all of your organs and your muscles. So some of those nerves go to your muscles, some go to your skin, some go to your visceral organs, your digestive system, your liver, your kidneys, your etc. And because your spinal cord is part of your brain, actually what happens is the spinal nerve ends inside the spinal canal. So that axon of the neuron that's in your brain finishes at whatever level. So let's say this is the nerve that's going to go down your leg. Okay. Well, the brain, the cell body's in the brain, the axon goes down the spinal canal and ends before it leaves the spinal canal. It ends inside the spinal canal. And at that point, it joins with what's called a peripheral nerve. Or when we say join, the proper term is it's synapses. It's synapses. That's where two nerves connect together. And so you have a cell body of that peripheral nerve, which is just like a central nerve, right? It just happens to be outside the spinal cord, so it's called a peripheral nerve. And then that peripheral nerve also has an axon. And the axon goes down your leg or to your liver or wherever it goes. Okay, and then at the end of that, it has nerve endings. So this cell body in your brain, okay, has an axon with nerve endings at the end, and those nerve endings connect to the axon of the peripheral nerve. So it's like a daisy chain of nerves. And then the peripheral nerve has its nerve endings at the end, and they connect to receptors that can sense temperature, vibration, etc. Or that connects to a muscle and tells the muscle when to fire. Or it connects to your kidney and tells your kidney when to secrete hormones, etc. So the nerves are essentially very similar, but the ones inside your brain and spinal cord don't actually directly sense what's happening in your body or in the outside world. All they do is connect to a peripheral nerve, which is just the same as a spinal nerve, but it just happens to be outside your spine, which then has an axon that goes to wherever that goes to, and that is where the sensory receptors are, or the motor interface is with your muscles. Thumbs up if that makes sense, or if not, ask a question. Okay, great. There's your spinal cord, and the nerve root is simply the cell bodies of those peripheral nerves. Right? Because if we think about this, the shape, the structure of a nerve cell, okay, there's the body, there's the axon, and there's the receptors, okay? Well, the body is thicker than the axon. right? So if we have a whole bunch of nerve cell bodies together, okay, then their axons trail off, the bit where the nerve cell bodies are is going to be fatter because nerve cell bodies are fatter than axons. Thumbs up if that makes sense. So when we look at this plastic model here, okay, and we see these nerve roots, and we can see that the nerve root is wider than the nerve tract, which is just the name for the axons, right? A whole bunch of axons together is called a nerve tract. Okay, so you can see it's fatter here and thinner as it goes away. Well, that fat part is called the nerve root. And that's just the cell bodies of all those peripheral nerves. And the Latin for root, you know, like a root of a tree, a root of a plant, okay, the Latin for root is radix. I don't know for sure, but my guess is the English word, the vegetable, the radish, which is a root vegetable, is probably just comes from that same Latin root. So radix means root. And then we have radiculopathy. Okay, opathy means something wrong. Radix means root. So radiculopathy is just something wrong with the root, or radicular pain, pain from a nerve root. Right, so that is the basic anatomy of the nerve, the peripheral and central nervous system. And just again for the scale, each nerve root has thousands of fibres in it. Thousands. All right, so when we say a nerve, what we actually mean is a nerve tract, which is a whole bundle of literally thousands of nerves. All right, so remember we said there are three kinds of sciatica. There's referring or radiating pain, radicular pain, and now you know what radicular pain is, right? It's pain caused by irritation of a nerve root, because you can see it in the word itself. It's pain from a nerve root. And then we have radiculopathy. And you know what radiculopathy is now, because it's just written in the word. It means something wrong with the nerve root. Okay, so referred pain. Referred pain is pain that spreads, and it can spread sideways, and you feel it in places that are innervated by different nerves. So if you have, well, let me share a little story here. I had a sore knee for a fair bit recently, and I had a pain in my knee that was very specific. It was on kind of the front inner part of the knee, just to the left of on the inside of the kneecap there. Very specific. But then over a few weeks, the pain spread out. And so then the pain spread right to the whole inside of my thigh, right? And also spread up into the muscles on the front of my thigh. And so that is radiating pain. That's referred pain. So that's not because I had an injury on the front inside of my knee and then the injury spread. What happened is the pain spreads. And the basic way that happens in your spinal cord. Now, there are some local mechanisms as well that happen to do with inflammation and things. But the main, I think, important concept to understand here is within the spinal cord. So referred pain is basically when there's crosstalk or a short circuit between adjacent spinal nerves. So imagine inside your spinal canal, okay, we have this sensory nerve that comes from the front inside of my knee. And then there's this other sensory nerve that comes from maybe the inside of my thigh somewhere. Right? A different set of receptors, not connected, but they just happen to be next to each other inside the spinal canal. Well, if for one reason or another, there's a little bit of a short circuit between those two nerves somewhere in the spinal canal, all of a sudden, there's a signal going up this one that says, hey, there's something going on in the front inside of your kneecap, okay? Well, that signal now is also going up this one, and now my brain's receiving a signal saying, hey, there's something wrong on the inside of your thigh. Right? Even though there's actually nothing wrong on the inside of my thigh. The pain just spreads. Thumbs up if that makes sense. Have you ever had pain that's kind of spread, like broadened out and got wider? This is the main mechanism. All right, so that's radiating or referred pain. Now, what would happen here, right? Think about this, okay? Well, so there's a nerve coming from the specific part of my knee where there's some kind of inflammation or irritation or something like that, right? And that's sending a signal right to my brain going, hey, something's wrong down here. And then that's sort of short-circuiting with another nerve that just happens to be next door to it in the spinal canal that feeds a muscle in my thigh, right? But there's nothing whatsoever wrong with the muscle in the thigh, right? So but I've got a pain in the muscle in my thigh now, right? So if I poke into that muscle in my thigh, is that going to hurt? What do you think? Think about the physiology. Probably not, right? Because there's no inflammation, there's nothing going on in the muscle in the thigh there, right? It's just a normal muscle doing its muscle thing, right? So it's just going to send a signal to my brain going, hey, someone's pressing you in the muscle in the thigh here. It's like, well, if you press yourself in the muscle in your thigh, it doesn't usually hurt unless you press unreasonably hard, okay? But if I press into the part of my knee where the original irritation was, what might I experience? Pain in the muscle in my thigh, right? It's going to radiate, okay, or refer to that part in my thigh because I'm sending a signal from the injured part of the knee, and that signal is spreading inside the spinal canal, and now I'm getting a signal from both that injured part and the uninjured part saying, hey, there's something wrong here. Michelle, what's your question?
My question is, if the original part of your kneecap pain then gave you the radiating pain, which was the first to resolve? Is there a pattern then of when things resolve? Does the radiating pain resolve first and then the original pain site, or do they both go away at the same time? Sorry, Raf, you're on mute.
Sorry, what a great question. And I'm sorry I don't have a science-based answer to that. So, yeah, I can only give you anecdotal opinions which aren't really worth anything. So I'm going to say I don't know. Great question, though. All right, so that is referred or radiating pain, okay, where there's actually nothing wrong with the other area. There's just some kind of crosstalk between the nerves, and so it feels exactly like there's something wrong in the other area, but there's actually nothing wrong. Symptoms, the location can be hard to define, but the centre's easy to find. So like I said, when you press on the bit that's originally injured, that's like, oh, that's the spot, right? But when you press around it, it's like, it's kind of, I think it hurts here, but when I press, it doesn't really hurt. So like, I can't really say, like it hurts, but I can't really say where it hurts. Okay, and it tends to be above the knee. All right, so that's referred pain, or radiating pain is the other name for it. Next is radicular pain. Now, you know what radicular pain is just by looking at the name, because it's pain from a nerve root, because that's what radix means. Okay, so pain from discharges, so nerve impulses originating from a nerve root. Okay, so if, we have our sensory nerve system here, so the part of the nervous system that brings sensory information from our skin, muscles, etc., into the brain. If there's an injury to the body, here's how we perceive that. There's some kind of injury to the tissues. Okay, maybe there's a minor muscle tear or something like that. Okay, that triggers a nerve impulse, a discharge of the nerve. That's what nerves do, is they send impulses. It goes up the peripheral nerve, into the spinal nerve, into the brain, and we go, there's something wrong in the calf. Okay, that's the sort of the mechanism of how that works. how we perceive radicular pain is very, very similar. So with radicular pain, there's an irritation of the nerve root. There's nothing happening in the calf. There's some kind of irritation of the nerve root, and that triggers a discharge of that nerve, a nerve impulse that goes up to the brain and says, something's wrong in the calf. Right? Now, your brain can't tell the difference. Right? I mean, just let's play this game, okay? I'm the peripheral nerve in the calf. Peri is the central nerve in the spinal cord, okay? The rest of you guys are the brain. Now, you can't hear me. You can only hear Peri because I'm out in the periphery. I don't connect with you guys, right? You've only got what Peri says to go on. So I'm going to send Peri a DM. You can't see it. Say, hey, Peri, something's going on here in the calf. Peri's job is to tell you. Raf says there's something going on in the calf, right? But then just say Peri just was feeling a bit mischievous one time, right? And she's like, hey, Raf didn't say nothing, but what the heck? I'm just going to say, hey, everyone, Raf says there's something going on in the calf, right? You can't tell the difference. You've got no way of knowing whether there is or isn't something going on in the calf, apart from the fact that Peri said it, right? So you just have to take her word for it. And that's exactly the same with radicular pain, right? The spinal nerve discharges, or the nerve root discharges, and it feels like there's something going on in the calf, but you can't tell the difference between a spinal irritation versus an actual injury in the calf. It feels exactly the same. With radicular pain, the pain tends to be in a line. Okay, it can feel like a muscle tear, muscle pull. Okay, it tends to be sharp. Lancinating just means sharp, stabbing. Okay, and it tends to be below the knee. Right, so then we have radiculopathy. And just looking at the word, you know, radiculopathy just means something wrong with the nerve root. And therefore, it's just an umbrella term that means something wrong with the nerve root. Okay, lots of things can go wrong with the nerve root. So all of those things collectively are referred to as radiculopathy. So radicular pain is a radiculopathy. Right? It's just one form of radiculopathy. Right, so you can have weakness. Why might you have weakness if you had radiculopathy? It's a rhetorical question, but I'd like you to think about the answer. This is in answer to Sarah's question in the chat as well. Well, in your spinal cord and your periphery, you've got essentially two sets of nerves. Okay, you've got nerves that bring information in from your body. So your brain knows, oh, there's a certain temperature and there's a certain amount of pressure and etc. Right? Your brain knows where you are in space and what's happening out in the world. And then there are nerves that send information down, away from your brain, which tell body tissues to do things. Right? They tell muscles to contract. They tell glands to secrete. They, tell your body to do stuff. Right? So in terms of the movement system, what we're mainly concerned with, we have sensory nerves and we have motor nerves. And motor nerves send information down from your brain to your muscles and tell the muscles to contract. Okay, and sensory nerves bring information up from the skin, the muscles, the tendons, the proprioceptors, etc. Tell your brain where your joints are in space and whether there's a temperature or chemicals or pressure or whatever. So we've got those two sorts of nerves, sensory and motor. Okay, so if you had something wrong with the sensory nerve, what symptoms would you expect? So say I go into your low back and I squeeze on the nerve root, the sensory nerve root, okay, of the nerve that goes down your leg. What symptoms would you expect? The answer is pain in the leg. Right? Well, just say I squeezed on the motor nerve root for the nerve that goes down your leg and tells your calf muscle when to contract. What would you expect? We expect some kind of weirdness in muscle contraction, right? Some kind of alterations. Now, it might contract spastically, like it might contract, without you sort of wanting it to contract, or it might not contract when you want it to contract. Right? So you might get weakness of that muscle. You might have a reduced ability to contract. Does that make sense? Thumbs up if yes, thumbs down if no. Okay, great. So one of the symptoms of radiculopathy could be weakness. Okay, and that would indicate that there are some motor nerves that are compromised. Could have numbness or loss of sensation, right? So if we irritate that nerve root, the sensory nerve root, we could cause it to fire off and tell your brain there's something wrong in the calf or the hamstring or wherever, right? But if we squish it hard enough for long enough and reduce the blood supply to it, reduce the amount of oxygen it's got, the amount of glucose it's got, it might stop working properly, right? It might stop discharging, and therefore we might experience numbness or loss of sensation. We might have reduced reflexes, which is just part of your sensory motor feedback loop. We can talk more about those if you want to in an anatomy lesson or at the end of today's lecture. And there's no reason you can't also have pain, right? So pain, weakness, loss of sensation, altered sensation, all of these things can coexist. Okay, now interestingly, you have in your sensory nerves, there are 4 or 5 different types of receptors, okay, and each sensory nerve receptor can only perceive one type of input, right? So it's not like you have a nerve that can kind of, detects, light and sound and temperature and chemicals and all these different things. You have one receptor to detect temperature and a different receptor to detect chemicals and a different receptor to detect pressure, right? So each nerve receptor can only perceive, or transduce is the proper word, information about one specific input. Okay, so remember we've got those 9,000 nerve cells in your L3 nerve root, right? 9,000. That's a crazy number, right? And why are there so many? Because they go down your leg, okay, and they go to your skin, and in each square millimetre of skin, you've got X number of nerve endings, okay, and some of those nerve endings perceive temperature, and different ones perceive pressure, and different ones perceive chemicals, right? And then the same inside your muscle tissues and in your fat tissues and in your tendons, there are all of these different little receptors that perceive different particular stimuli, right? Now, if that nerve root is irritated, and it just so happens that the particular parts of that nerve root, of those 9,000 neurons, okay, in there, maybe 400 of them are irritated, okay, and it just happens to be that the 400 that are irritated, okay, a lot of them sense temperature, right? Well, you might feel that your leg is cold, or that there's water running down, cold water running down the back of your leg. Or if there are ones that detect pressure, you might feel that there are ants walking on the back of your leg. There's something on the back of your leg. Does this make sense? Or if there are ones that detect chemicals that are irritated, you might perceive a burning sensation, right, on the back of your leg, right? So it depends which particular nerve root, which particular nerve fibers are irritated, is going to determine what type of symptoms you get. Okay. So people can get all kinds of weird and wacky symptoms in radiculopathy. Right, so radiculopathy, conduction is blocked. Okay, so we just basically throttle off that nerve root and we squeeze it maybe, or reduce the amount of oxygen that it gets, or glucose, etc., and it just can't do its job, right? So it should fire, but it just can't fire as much, so the signal doesn't get through. Right, so now you prick me in the calf muscle with a pin, and the signal doesn't get up to the brain. And so we have these 2 types of fibers, like I said, sensory fibers, and motor fibres. Okay, and so we already talked about that. Anna, what's your question?
Hi, Raf. Hi, everyone. I was just wondering, well, I'm not very close to this topic, but I was wondering, so when someone goes to have like a nerve blockage, you know, that they block the nerves, would they be also maybe at a risk of also having any sensory change? Because I guess that finding just one nerve root should be a very complex thing to do. So
Yeah.
So okay.
Yes, so you can. They do, surgical nerve blocks. So they can sometimes we're going to talk about that actually. They can use radio frequency to X-rays to kill the nerve. They can inject lidocaine, which is an analgesic, like a pain medication, what you have when you go to the dentist usually, into the nerve root to test if the nerve root is causing the problem. So there are different ways they can do that. I'm not really clear on the exact techniques they use. My guess is, though, it would be basically impossible to be, specific to which particular fibres within the nerve root you wanted to impact. So you would just basically have to do it for the whole nerve root or not at all. That would be my guess based on the physiology, but I don't know for sure. Good question. All right. Now, when we have radiculopathy, there's something called a dermatome. And derma means skin. Okay. So dermatoma was just the pattern of where the sensory loss is. So, if the L3 nerve root is irritated, it will be supposedly, above the knee where the pain is, right? Or the irritation is. And then we've got these whole maps of dermatomes, which you may or may not have seen. So if we actually just go and look at dermatome here on Google, you'll see it's just these kind of maps of, and this is a map of okay, here is where this L3 goes to the knee here and L4 to the floor and blah, blah, blah. Okay, these little mnemonics that I learned in school to remember where they go. So you can go, if I've got pain here, that means it's caused by the L4-5 nerve root in my low back, right? So you can sort of figure out where the irritation is in the low back based on where the symptom is, okay? But it turns out that those aren't very reliable because people's nerve tracts are highly variable. And so some people, the nerve tract exits at the L3, other people it exits at the L4, other people it exits at the L2. And so you can't really reliably trace these things. Weakness is myotomal, and I'll explain what that is in a moment. All right, so what is sciatica? Type it into the chat. And the answer is sciatica is an umbrella term for leg pain or symptoms, really, caused by some kind of irritation of a nerve root in the low back. What is a nerve root? The answer is a nerve root is the cell bodies of the peripheral nerve where they synapse or join with the exiting spinal nerve. What is radiating, or otherwise known as referred pain, caused by? Try not to look at your notes. The answer is crosstalk between spinal nerves from different sensory areas. What is the difference between radicular pain and radiculopathy? The answer is radicular pain is pain caused by irritation of a nerve root. Radiculopathy is an umbrella term just meaning something wrong with the nerve root. So radicular pain is one type of radiculopathy. Okay, so we saw that low back pain is pain, tension or stiffness between the rib margin and the gluteal fold with or without leg pain, and that sciatica is leg pain from a nerve root. So question, is sciatica low back pain? Type it into the chat. The answer is yes, it is. All right, low back pain is biopsychosocial. Back to ACSM, page 172. Read with me. We're about... Where are we? Actually, we're on page 173 here. Current literature does not support a definitive cause for initial bouts of low back pain. Does not support a definitive cause. We don't know what causes it. Same page. The best available evidence supports a classification approach that de-emphasizes the importance of identifying specific anatomical lesions. A lesion is just something wrong after red flag screening. So we should screen for red flags. After we've cleared red flags, we should de-emphasize the importance of identifying specific anatomical lesions, because current literature doesn't support a definitive cause for low back pain. So we can't identify a definitive cause once we've ruled out red flags. So we shouldn't emphasize identifying specific anatomical lesions. The biopsychosocial model is the prevailing framework used for understanding, managing, and treating back pain. This approach suggests that in addition to biology, discs and nerve roots and things like that, biology, psychological, socioeconomic, environmental, and cultural factors all contribute to the incidence and persistence of back pain symptoms. Here is a non-exhaustive list from the ACSM, and you can see this in your guide if you're following along, of psychosocial factors. A negative attitude, these are psychosocial factors that correlate with long-term disability and work loss from low back pain. A negative attitude that back pain is harmful or potentially severely disabling. Fear avoidance behaviour and reduced activity levels. Okay, so what should we do instead of, or to help people with that? Well, we should become a movement optimist. Okay, that's the opposite of a negative attitude that movement's potentially harmful. And the opposite of fear avoidance is being a fearless movement optimist. The next one is an expectation that passive rather than active treatment will be beneficial. Okay, we know that active treatment works better, so what should we do? Get moving. Okay, a tendency to depression, low morale and social withdrawal and social or financial problems can all perpetuate low back pain. So what should we do? Build psychological resilience. Okay, I don't know, does that sound a little bit like the whole person framework to you? All right, low back pain clinical practice guidelines from the ACSM. You can follow along and read these. Clinicians should not utilise patient education and counselling strategies that either directly or indirectly increase the perceived threat or fear associated with low back pain, such as education and counselling strategies that promote extended bed rest or provide in-depth pathoanatomical explanations for the specific cause of the patient's low back pain. So the clinical guideline says don't tell them it's their disc or it's their arthritis or it's their facet joint or it's their insert, itis, osis or opathy, right? The guideline specifically says don't say that to your clients after we've screened for red flags. Patient education and counselling strategies for patients with low back pain should emphasise the promotion of the understanding of the anatomical and structural strength inherent in the human spine, the neuroscience that explains pain perception, I don't know, like the cup metaphor, the overall favourable prognosis for low back pain. Prognosis means what's going to happen. The use of active pain coping strategies that decrease fear and catastrophizing, like getting moving, okay, and not avoiding activities. The early resumption of normal or vocational activities, even when still experiencing pain. So even when you have pain, it's safe and in fact it's beneficial to get back to work, to get back to your valued activities. The importance of improvement in activity levels, not just pain relief. So we can help people with pain. We should also focus on helping people get moving and getting back to doing what's important to them, even if they still have pain. All right, so in other words, the biopsychosocial model says lots of things contribute to pain, like poor sleep, worry, low physical activity, low self-efficacy, many other things, and including tissue status. Because it's biopsychosocial, it's not just psychosocial. So we have tissue status. And so, for example, disc bulge is one of the things that people will come to you with, and that's an intervertebral disc bulges beyond the margins of the vertebrae that it joins, right? So there is a bulging disc. It's also called sometimes a disc herniation, a disc prolapse, a slip disc, which is not a real thing, a disc extrusion, a disc protrusion, a disc sequestration. But are disc bulges responsible for pain? Well, it's complicated because the incidence of disc bulge in pain-free people is quite high, even in young pain-free people, and it increases significantly with age. So these are in pain-free people. But disc bulge is more common in people with pain. So it's very common in pain-free people, but it's more common in people with pain. So does it cause pain? Don't know. New onset low back pain is not associated with new imaging findings. In fact, 84% of people with new low back pain had the same or regressed, which means it healed, okay, same or regressed MRI findings compared to baseline. So if we MRI people who don't have low back pain and then 2 years later we MRI them again and we go, okay, some of these people have developed low back pain in the time and some haven't. What we find is the people who developed low back pain on average had better imaging after their low back pain started. Fewer disc bulges after their back pain started than before, right? So that's a head scratcher. There are no clinical tests that can accurately identify the disc as a source of pain. Right? There's like, if we wanted to be certain that, okay, yes, it's the disc that's causing the pain, it's like, well, how would we test for that? The answer is we can't. When we destroy the nerve endings, so this is radio frequency denervation trial. I had about 270 people in 2017, and this is exactly the same process they use to kill malignancies, right? So if you have prostate cancer or breast cancer or some other cancer, and you'd get radiotherapy, that's what this is, right? They aim X-rays at the tumour in the case of cancer, or in this case, they aim X-rays at the nerve endings, because discs have nerve endings in them. And so these are people who had pain in, supposedly from their discs, okay? And they burnt the nerve endings. So they literally had no nerve endings on their discs, right? And then they had people who had sham radiofrequency denervation. Oh, sorry, this one wasn't sham. This one was, they just had exercise versus exercise and just exercise rehab. And what they found was the people who had exercise rehab had the same amount of pain improvement as the people who had radiofrequency denervation plus exercise rehab. So the radiofrequency denervation didn't add any more pain relief, which is kind of crazy considering they literally burned off the nerves, right? Denervation, right? There's no nerves. They cut, they kill the nerves, right? So well, if the pain's coming from the disc and then we kill the nerves in the disc, you'd expect there to be no pain, right? But that's not what happens. So is the pain coming from the disc? And the answer is, remember, if you're a brain in a vat, you can still have back pain, right? Because you don't need... Remember we saw those studies earlier on about phantom limb pain after people have their limbs amputated? Right? Well, if you can have pain in your knee without having a knee, okay, the fact that you've got pain in your knee doesn't even tell you that you have a knee. Right? Let alone it doesn't tell you that there's something wrong in the knee. It doesn't even tell you that you have a knee. Right? So you can have back pain without having a back. You can have back pain without having something wrong in your back. Because we can cut the nerves to your back and you still have back pain, which is, go figure. Cutting out the part of the disc doesn't change the pain. This is microdiscectomy, okay, surgery. When I say it doesn't change it, I mean it doesn't change it more than either sham surgery or just exercise rehab. Right, so it does help. It just doesn't help more than something that's not that. And MRI findings do not predict future low back pain, but they do predict worse outcomes for people with current low back pain. Now, disc bulges heal, and there's different grades of disc bulge, and I think this is in the coursework. If it's not, I'm going to put it in there. What each of these things is. Okay, but these are essentially more severe. This is very severe, this is very mild, right, in terms of how serious it is. Chance of it healing in 12 months goes up with severity, right? So the disc bulge, very unlikely to heal. Sequestration, almost certain to heal. Which is pretty cool. The more severe it is, the more likely it is to heal. But weirdly, okay, even though, and this was a different study, so the percentages are slightly different, even though those disc bulges and herniations, whatever, have a different likelihood of healing, the chance of pain resolving is the same, right? So the pain almost certainly resolves whether or not the tissue changes, right? So if we go back to these people, okay, and we go, a year later, your sequestration's gone and your pain's gone. A year later, your disc bulge is still there, but your pain's gone. Right? So the pain going away and the disc bulge going away or not going away don't seem to be very well correlated at all. Marie?
Yeah, just a question. Do you think, or do you know whether it's about the space that's getting bigger again when it kind of resolves the bulging, or doesn't have to do anything with the space for the nerve?
Yeah, I'm not aware of a study that looks directly at the disc height and pain. But I've just done a couple of podcast interviews with researchers on disc degeneration, which is really associated with disc height and pain. And the short answer is we don't really know. We don't have that data.
Yeah, because from what you just said in the slide, it also says apparently it doesn't make a difference whether there's more space for the nerve or not, because the pain goes away anyway, right?
Right, and we're going to talk more about that in a future lecture, but basically sciatica can be caused by, like we think about compression of the nerve, like we think about something physically pressing on the nerve root, like a disc bulge or a bony outgrowth or stenosis, like a narrowing of the spinal canal, something like that, okay? But actually, most of the time, it's not physical compression, it's inflammation that causes sciatica. Oh. So it's irritation of the nerve root by inflammation, which increases the pressure within the spinal canal and also releases like histamines and other sort of pain-promoting substances. So you can have irritation without compression. In fact, most sciatica occurs in the absence of compression. And vice versa. You can have a lot of people who have no sciatica who have significant nerve compression on MRI. So the compression is like it's a factor, but it seems to be pretty unimportant. It's neither necessary nor sufficient to have compression in order to have sciatica, but it is necessary and sufficient to have inflammation around that nerve root in order to have sciatica. So if you want to have sciatica, compression's optional, but you have to get some inflammation happening in there. So yeah, I don't really know about the disc height thing, but I suspect it's probably whatever's associated with the change in disc height. There's probably some inflammatory processes associated with that, and it's probably more about the inflammation than it is about the actual mechanics. Really good question. All right, disc degeneration. Disc degeneration is mostly genetic. So there are some twin studies that look at, identical twins who do different sort of physical activities. One's a construction worker and one's an accountant, for example. And what they find is at 50 years old, they have identical discs, right? So the discs seem to be mostly, the disc degeneration seems to be mostly influenced by genetics rather than activity levels. There is some evidence that activity may improve disc degeneration, and I just did a podcast on this. It'll be released in about 4 weeks, but it's at the moment I would say it's we don't have prospective evidence. We've got sort of observational evidence that can help. So disc degeneration is very common in pain-free people. So this is from 2015, Brinjicci et al. Systematic review of imaging findings in pain-free people. And if you look at disc degeneration, it's extremely common in pain-free people at every age and gets more and more common with advancing age. So without a doubt, of the majority of us on this call would have disc degeneration, right? So with or without pain. So do disc bulge and disc degeneration cause pain? Well, the answer is it's complicated, okay? And we don't know is the very short answer. But they probably don't cause pain, but they probably do contribute to pain. And so if we think about the cup of resilience as the overflow is pain, okay, well, the things that we pour in to the cup, we can't say that the disc bulge or the disc degeneration caused the pain, but we can say that the combination of all of these things caused the pain. So each of these things contributed to the pain, right? If there'd been fewer disc bulges, but still all of these other things, maybe there would have been no pain, right? But if there'd still been disc bulges, but maybe there'd been some of these things different, or maybe we could have had the disc bulge with no pain. Right? So it's not necessarily the case that I don't think it's a useful question to ask, does it cause pain? Because the answer is no, there are plenty of people with disc bulge who have no pain, so it doesn't cause pain. But it's more common to have pain in the population who has a disc bulge or a disc degeneration, right? So it's not irrelevant, it's a factor, right? I don't know, like a couple more metaphors. Do kids, make you insane? I don't know. Well, there are plenty of people who've got kids who aren't insane, right? So the answer to that is no, kids don't make you insane. But do you sometimes get a bit more insane when you've got kids? I would say probably yes, right? So they're one of the things that can, nudge you in that direction, okay? Along with, guess what else? Low sleep, poor social support, not looking after your physical health, all of those other things, right? So if you've got kids and you look after all of those other things, you've got happy relationships and you look after your health and you get enough sleep, well, maybe the kids won't make you insane, right? But if all of those other things weren't going well and you had kids, well, you might tip over the edge from time to time, right? Another metaphor, cake, right? We put in eggs, flour, sugar, whatever else goes in to make a cake, okay? Do eggs cause cakes? No. If I put eggs in a bowl, that's not a cake, right? Are eggs part of what makes a cake? Yes. If I put flour and milk and sugar in a bowl, is that a cake? No. If I add eggs, that now becomes a cake, right? So are eggs one of the things you can use as part of that process? Yes. If I just have eggs by themselves, that's not a cake. Now, can I make a cake without eggs? Yes, I can. Right? I can put in some banana to make it all stick together, whatever, okay? So you can have eggs without it being a cake, and you can have a cake without having eggs in it, but having eggs in there does help it along, does help it become a cake, right? So you can't really say, look at the cake and go, oh, the eggs caused this. It's all mixed in together. It's the whole thing that is, it's a system, right? So same way with disc bulge, disc degeneration. Do they cause low back pain? No, they don't. Are they part of what contributes to it? Yes, they probably are. All right. What is the definitive cause of low back pain? The answer is we don't know. There probably isn't one. What's the cause of cakes? What's the cause of parents going insane? True or false? It is best practice to give a detailed pathoanatomical explanation of the specific cause of pain. The answer is false. What is disc bulge? Okay, so I think I didn't explain this very well because I see almost everyone answering it incorrectly. So that becomes a me thing, not a you thing. So a disc bulge is just where you have your vertebrae, okay, and the disc, here's a normal disc. Okay, and the disc is the same width as the vertebrae. Okay, in a disc bulge, the disc protrudes beyond or extends beyond the margins of the vertebrae. Okay, so the disc is wider than the vertebrae. That's the definition of disc bulge. Right, so protruding, yes, it's kind of sort of right, but like specifically it protrudes past the edge of the vertebrae. Judith.
But doesn't this also sometimes go inwards instead of outwards? So that would be within the limits of the vertebrae?
Disc. No, the definition of a disc bulge is it goes outwards. It bulges outwards. Yeah. And so there are different types of disc bulge. If we look, and there's a lesson on this, so I don't want to spend, more than a few seconds on it. But if you look at for the top view, okay, here's the neural canal, transverse processes, spinous process, okay. If we look at the top view, there might be a circumferential bulge where it goes bulges out all the way around, okay. Or there might be a focal herniation where it just bulges out a little bit, okay? Or there might be an extrusion where it's kind of narrow and deep. It's like just describes different shapes and sizes of disc bulges, all of these different things. But a bulge is basically any of the above where it protrudes beyond the edge of the vertebral body. All right, so let's get back to this. What is disc degeneration? Try not to use your notes. Right, I'm just looking at those answers come through and I'm thinking, yeah, I didn't do a great job of explaining this either. So let me explain degeneration briefly for you. All right, so degeneration is where you have your adjacent vertebrae, okay, and you have your disc. And if we look at a cross-section of the disc, okay, so if we just kind of sliced it down the middle and looked at it from the side, we would see that the disc is made of the disc walls, which are called the annulus, and annulus or annual means, like, think about an annual calendar, right? It's something that goes the year that comes around again, right? So something annual is something that comes around. It's like circular, okay? So the annulus is the circular outer part of the disc. Right, it's the outer skin, it's the tough outer layer, and it's comprised of multiple layers of ligament, right? So it's like, if we look at it from the top, it's like a coiled ligament wrapped around and around and around and around and around, okay, with a hollow space in the middle, okay? This is the top view. So if we look at that annulus, the outside part there, okay, and on the inside, there is a nucleus. Nucleus, okay, and that is liquid, and anytime there's a liquid in the body, it is made of mainly water with a few bits floating in it. Right? So that's basically water that you've got in there. Now, the bits floating in it are mainly proteins, okay? And when you put proteins in things, do you know, like in your real life, do you ever put proteins in water? Do you ever mix up, just get some water and put some proteins in it? Well, if you do a protein shake, yes, but what about if you make jelly or Jell-O, right? Well, do you know what jelly crystals are? It's just protein. It's powdered protein. Right? They get, I don't know, horse tendons or whatever they get, okay, grind it up into a powder and add some sugar and some flavorings and some colorings and whatever. Bam, that's jelly crystals. Okay. Protein makes things sticky. Okay. Protein makes things sticky. So makes it viscous, right? Think about jelly. It solidifies, it becomes more solid. Okay, so the nucleus is water with some proteins, so it's not like watery water. It's kind of thick, viscous water, not quite as thick as honey, but heading in that direction. Right, so it's thicker and gloopier compared to water, and so you've got this, this hydration in here. Okay, which then allows the bone, the vertebral bones to kind of bend forwards and backwards. Okay, and also to absorb shock. Because as this compresses down, okay, this can bulge out a bit and this can squish down a bit, okay, and then it springs back, right? It's kind of a shock absorbing system and it's a movement system, Okay. Now, what happens in disc degeneration is the disc doesn't wear out. It's not a wear and tear thing. Remember we said it's a genetic thing? Okay. What happens is the water leaks out. So now you've got less water in there. Okay. So you've got less water. So you've got your two adjacent vertebrae. Okay. And now you've got less water in there because some of it leaked out. Okay. But you've still got that ligament. Okay. And the ligament's still the same size. So where does the ligament go if these two vertebrae are closer together? Well, what happens is it bulges out. It bulges out. Does that make sense? If we made that shorter, well, it has to go somewhere. It can't just go nowhere. Okay. So now we've got a shorter, the height is decreased there. So if the spine wants to bend, guess what? Those two vertebrae run out of room quicker, right? There's less room for them to bend, okay? And there's now less shock absorption there as well, okay? And so why does that water go out? Well, lots of reasons. Maybe the protein content in there becomes different, okay? We have proteins in there that attract the water. Maybe we express fewer proteins and we have fewer proteins in there, so there's less water in there. Okay, that's a genetic thing because your DNA makes proteins. That's what DNA is for. Okay, maybe the annulus develops kind of little cracks in it and the water can leak out. Okay, a bunch of reasons. We're not really sure what causes it basically, but it seems to be genetic. Okay, so now it's not a wear and tear thing. It's just dries out, right? And because it dries out, it loses height. Thumbs up if that makes sense. Okay, great. So I'll repeat my question. What is disc degeneration? Okay, sometimes they call it disc desiccation because to desiccate means to dry out. Sometimes they talk about annular fissures. The annulus is that tough outer layer, and a fissure means a crack, right? So all of those things, annular fissures, disc desiccation, disc degeneration, all of them kind of mean the same thing, the disc drying out and losing height. And it often goes with a disc bulge because it just bulges out when it loses height. Okay, good answers. What is the relationship of disc bulge and disc degeneration to pain? The answer is not none. The answer is it's complicated because lots of people with disc bulge and disc degeneration have no pain, but it's more common to have pain with disc bulge and disc degeneration. So there's not no relationship, but it's a complicated relationship and we don't really understand it. List 4 factors that can contribute to back pain. Try not to look at your notes. Okay, basically anything that goes into that cuff of resilience. Financial stress, lack of physical activity, poor sleep, social isolation, tissue status, don't forget tissue status, inflammation. Okay, great. All right, so we saw that low back pain is pain, tension or stiffness between the rib margins and the gluteal fold with or without leg pain. That sciatica is leg pain from a nerve root, which is also low back pain. That low back pain is biopsychosocial, and that we're going to see now that most low back pain halves in 6 weeks, then halves again at 6 months, and then halves again at 12 months, regardless of treatment. All right, and this is a very short section. Natural history is just what happens if we do nothing. And it turns out in low back pain, it gets better if we do nothing. This is from the ACSM again. For prognosis outcome, well, that's where that slide went. Okay, so from this 2012 meta-analysis of natural history of low back pain, we basically see that what I just said, right? That's what happens to low back pain over a year if left untreated. All right, very short section. What is the natural history of low back pain? The answer is it's going to get a lot better in 6 weeks and then continue to get better over the next year. Okay, low back pain is pain, tension or stiffness between the rib margins and the gluteal fold, with or without leg pain. Sciatica is leg pain from a nerve root. Low back pain is biopsychosocial. Most low back pain halves in 6 weeks, then halves again at 6 months and halves again at 12 months, regardless of treatment. Finally, 95% of sciatica resolves in 12 months, regardless of treatment. Judith.
So if the natural history, it goes away, like it halves in 6 months and then 6 weeks and then 12 weeks, what is chronic lower back pain? Like, how do you explain that?
Well, the answer is 3 million studies. We can't explain it. And when we say it halves in 6 weeks and then halves again at 6 months, we don't mean for everyone it exactly halves. What we mean is on average. Okay, so for some people, it goes away completely after 6 weeks. For other people, it gets worse. But on average, it halves in the first 6 weeks and then halves at 6 months.
Okay.
All right. 95% of sciatica resolves within 12 months regardless of treatment. And sciatica resolves regardless of radiological findings, so whether there's a disc bulge, a disc degeneration, a nerve root, and blah, 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 regardless of neurological deficit. So if I've lost feeling in my foot or my quads won't contract, that doesn't affect prognosis. Nerve root tension signs, so if I'm doing like different kind of nerve root tension tests, going, oh, does that irritate your nerve root, etc. Those aren't predictive of resolution, duration of symptoms, age, or previous history of sciatica. So none of these things predict whether it's going to resolve. It resolves in almost all cases regardless. And finally, diagnostic imaging does not reassure patients. So we've had, you've probably heard people saying, like, I just want to get a scan just to be sure, just to be on the safe side, just to, just so I know what's going on. What happens is, guess what? They have a scan, they're probably going to find something because a large percentage of people have, if you look at pain-free 40-year-olds, 50% of them have a disc bulge, 68% have a disc degeneration. If you add those two things together, the chance of a pain-free 40-year-old having something is very, very high, right? And once we add in arthritis and all the other itises, otises, and opathies, the chance of them finding something on the scan is virtually 100%, right? So what happens when people have scans is they find stuff. And then what happens is that doesn't reassure people. They actually feel worse because they think, oh, no, I've got this disc degeneration, which means degeneration sounds like it's going to get worse and worse and worse and worse. Okay, and many people think mistakenly that it's a wear and tear situation. So my back is worn out is the message that often people get, which doesn't reassure them. So scans don't reassure. And remember the ACSM, the best available evidence supports a classification approach that de-emphasises the importance of identifying specific anatomical lesions after red flag screening is completed. Okay, we're almost at the end. What is the natural history of sciatica? Or if I've got really bad sciatica and I wanted to come do Pilates with you, how long would you say you would guarantee you would get rid of my sciatica with special Pilates exercises? So if you do Pilates with me for 12 months, I can pretty much guarantee that your sciatica will be gone. What structural factors influence recovery in sciatica? The answer is, for most people, none. There are a couple of small asterisks on that, which we can talk about later if you want. So, for instance, if you had a disc sequestration, yes, the structural factors would be important there. But the good news is 96% of disc sequestrations heal within 12 months all by themselves. Which structural factors influence treatment of sciatica and low back pain? The answer is, once we've ruled out red flags and specific causes, they don't. True or false? It's useful to use alarming pathoanatomical explanations for pain. The answer is false. If structural factors don't influence recovery or treatment or reassure patients, what's the benefit of paying attention to them? It's a head scratcher, isn't it? Well, we should rule out red flags, as a couple of you have mentioned, and people often are curious. Like they have a scan report that says their disc is bulged or degenerated, or they've got arthritis or tendinopathy or something like that. So it's not good to brush that off and ignore it, but at the same time, we shouldn't focus on it. So how do we, find a balance between acknowledging and reassuring the patient and the client about their concerns and addressing those concerns, whilst not enhancing that concern and anxiety that they have? That's a conversation for another day. All right. Low back pain is tension, stiffness, or tightness or pain. Pain's tension or stiffness between the rib margin and gluteal fold with or without leg pain. Sciatica is leg pain from a nerve root. Low back pain is biopsychosocial. Most low back pain gets better in a year. 95% of sciatica resolves in a year regardless of treatment. Okay, now there's some bonus content which you can just look at in the PDFs and stuff. But if you have questions, let's take those now. Michelle.
Sorry, I thought I put my hand down, but I'll just say it quickly. Just a quick comment is that I feel that my way of working with clients has now aligned with my way of working with children, in that, say, for example, when a child falls down and hurts themselves, if I as the parent go, oh my God, it's the same sort of thing as when a client walks in and says, I've got a scan to show a disc bulge. I'm not going to go, oh, same thing.
Right. And when the child comes in, depending on the age of the child, but you go, oh, yes, darling, there, mummy will kiss it better. Is that better? Put a Band-Aid on it. Good. Okay, off you go. Play now.
Yes. Yeah, exactly.
Anybody else got a question that I missed in the chat or anything that you want to talk about? Debbie?
I just have a question about dealing with people with sciatica. Like, I totally understand, it's going to resolve in a year, but a year is a really long time.
And sometimes it can take longer than a year.
Yeah, exactly. And so like years ago, I had a client who it came on, out of the blue, blah, blah, blah. And then she didn't want to come to Pilates. She didn't want to do anything because she was so afraid of that pain because it was so horrible, understandably. And then, like she finally came back after it kind of got a little better or whatever. But then it was just, this ongoing saga of like, just being fearful of different things. And now, of course, post this course, like I, have a different approach to that. But in general, how do we, what is the best way to manage these people or their pain during this time period? Well, it's over this year or whenever.
All right. So there's the zoomed out version. Okay. If we zoom out to Earth orbit, okay, all we can see is the continent of Africa and the Great Wall of China. Build a therapeutic alliance, build physical capacity, build psychological resilience. Okay. It's exactly the same. We zoom in a little closer, okay, and look at the specifics of sciatica. Well, it's, what do people want to know? They want to know, why does it hurt? Okay, what's going to happen? What can I do? What are my treatment options? Okay, and so we want to explain that to them in as simple terms as possible that actually makes sense to them. So why does it hurt? Cup of resilience. Okay, use the cup of resilience or any other metaphor. Okay, that's not we've got research showing that there's no metaphor that's better than other metaphors, but just use some metaphor to explain it to her and say, okay, one of the things that's contributing to this is inflammation or, degenerative changes or whatever in your low back, whatever her scan was, okay? And a bunch of other stuff also contributes to this, okay? And so the degenerative changes or the inflammation or whatever are going to resolve themselves very likely. In the vast majority of people they resolve, it generally takes about a year. Some people a bit less, some people a bit more, but that's, for the vast majority of people, it's about a year, okay? And in the meantime, there's lots of other things that we can do to influence your symptoms because we can impact your sleep and your stress and your physical activity and your fear and your coping strategies and your social support and all these other things that we can influence. So, let's work on those, right, whilst we twiddle our thumbs and wait for nature to cure the disease. Okay? And there are also a couple of physical things that we can do, which we're going to cover not next week, but the week after in terms of assessment and directional preference.
Thank you.
Marie.
I just wanted to point out also that if you go through the whole process of screening and everything, you get into this cycle of no seeping information from weird doctors. That's what I'm experiencing right now. So what this other participant before asked about the chronic pain definition is also interesting for me because the doctor said to me, and I've been going through sciatica since November last year, without any specific reason other than COVID. And I've been doing my deadlifts from between 70 and 80 kilograms 2 weeks before the scan happened, which I felt bad about because after the scan, he said to me, you should not lift anything heavier than blah, blah, blah. And it would slip even further and it compresses the nerve even more and the pain gets chronic, blah, blah, blah. I was like, oh my God, all that information just made me feel worse. I mean, the pain has been worse since then. But I think it's other reasons than that. But my problem now is, what do I do now? Like, do I not lift anymore? Or for how long do I not load that much? Or, all these questions I'm not scared. I know that it will resolve itself, but what is my go-to plan now? Because the suggestion is to get steroid injections into my spine, and I don't want to do that. And so, I'm a bit lost for what to do. That's the only thing from all these weird information.
You're on mute, Raf.
Sorry, what does the scan say, Marie? What's the diagnosis?
The diagnosis is disc bulge, like a severe one, and a tear in the annulus, like the rings, there's dehydration happening, and the S1 nerve root is quite compressed. So I think it's from that, but it's also from lack of sleep, probably, and stress. Mm-hmm. So there is various different things, but there's definitely a huge disc bulge. Mm-hmm. That's what came out.
Mm-hmm. And do you have any motor weakness?
Only sometimes. It's rather a tingling down to the whole back of my leg into my big toe, and I can't do hip flexion and a hip flexion with a straight left leg, like not at all. No rollovers, no roll ups, not that kind of stuff.
Because of pain?
Because it's shooting pain, but I can do deadlifts of 80 kilograms, like no problem. It's very strange.
So I'm not aware of any evidence that lifting is contraindicated in sciatica or with disc bulge. So if it were me, I would keep deadlifting if I love deadlifting, which I do. And I would err on the side of being a bit conservative. So rather than doing like 80% of your 1 rep max, I would start on maybe 60% of your 1 rep max. Don't go to absolute failure. Stop 3 reps short of failure. Wait a few days, see how you pull up. If you pull up good, do it again. Do that for a couple of weeks. If you still feel good, go to 65% of your 1 rep max. Just progress gradually. Give it 3 days after each session to just settle and see how you feel. If you feel good, great, keep doing it. If you don't feel good, regress it and go to 50% of your 1 rep max or 40% of your 1 rep max, or put the barbell on blocks, so you're lifting from a less flexed position.
Yeah. Okay. Would you do the injections though, or not?
I'm not aware that steroid injections have any greater benefit than not having steroid injections. I think they give temporarily, slight temporary relief. Like if it's that bad that, a 2 out of 10 pain reduction for 3 weeks would be significant for you, then go for it. But that's probably about all you're going to get.
Okay. Thank you.
And we'll do some directional preference stuff in a couple of weeks. And if you want to come do a session with me, just DM me and we'll book a session.
Thank you.
Michelle.
Hi. Oh, sorry. It's 2 of us today.
You can go first. No worries.
Okay. I had another question, and it may be covered in the later lecture that we have on sciatica, but I was told by a physio that the combination of spinal flexion, hip flexion, extension, and ankle dorsiflexion, I'm sorry if that's me or someone else, I don't know, but it exasperates it, it makes it worse. Is that something that we'll talk about, or is that something that you've heard before?
So that isn't something, well, we're kind of going to talk about that, but we can talk about it now. I think so. Basically, your sciatic nerve, if you think about your sciatic nerve, there's your spinal column, there's your pelvis, there's your leg bone, etc. Your sciatic nerve is part of your brain. Okay, it goes all the way down through your spinal cord, exits at about L45, L5S1, and then it synapses with the peripheral nerve, which is also part of the sciatic nerve tract, which then goes down there. So basically, this is one long structure, okay, that goes all the way from here to here. Right? Now, when you bend your head forwards, bend your back, straighten your leg, and dorsiflex your feet, okay, you stretch out that nerve to its longest possible stretch. Okay. On the other hand, when you bring your head backwards, bend your knee, and plantar flex your foot, okay, that nerve kind of gets shortened. You know, there's slack in it. Okay. Does that make sense with my kind of drawings that look a little bit like an unborn child in one, you know, like a 4-week-old fetus on one side and some kind of crazy worm on the other side? Can you kind of make sense of that? All right. So now just imagine that there's some kind of, entrapment of the nerve in the low back. Like maybe there's a disc bulge, maybe there's osteophytes, you know, like little bony growths on the neural foramen. Maybe there's a stenosis, the narrowing of the spinal canal. For whatever reason, let's wave a magic wand and say, okay, the nerve is a bit trapped, like it's not slide. So basically, as you move your leg and you go from this position to this position and back and forth again, okay, that nerve kind of slides up and slides down throughout its whole length, right? It's imagine if it's literally a piece of string going through there, okay? It would, you know, as your head goes forwards, okay, and your leg goes backwards, well, that nerve's going to slide that way because the head's going to pull it this way, okay? And as your head goes backwards, okay, and the foot goes forwards, well, the nerve's going to be pulled this way because the foot's going to pull it this way. Right, so can you picture it kind of going to slide back and forth in its nerve tract? Okay.
Yeah.
So if it's a little bit trapped, right, again, there's osteophytes, there's a disc bulge, there's something there that's kind of causing it to not slide freely, okay? Well, when you try and lengthen it out here in this fully stretched out position, it's going to not lengthen one way or the other, right? Somewhere it's going to be stuck. Right. And so you're going to go, oh, ouch. You know, the more I straighten this leg, the more that pulls. Right. That's probably what Marie's feeling as she does. This is the rollover position, right? So we put the arms here. You know, we flip this over on its back. That's the rollover. Okay. And so that's why, you know, in the rollover, the sciatic nerve is maximally stretched. It's at its longest possible position. Okay, and so if there's an irritation or if there is, you know, there's a maximum tension, there's tension on the nerve in that position, like physical tension. It's being pulled, like a piece of string being pulled from both ends. So if there is an entrapment or an irritation or tension on that nerve for whatever reason, that's going to aggravate it. And that position is also what's called the slump test. So the slump test is a test. I'll see if I can show it to you now. Maybe I can get this low enough. So this is a test you can do to test. It doesn't really tell you for sure, but it increases or decreases your confidence that someone's pain in their leg is caused by something in their low back. Right? So just say I've got sore hamstring, right, or sore calf or whatever, right? Well, you sit me here and you get me to slump, right? Because now, can you picture that nerve stretching out through my back? Okay, and then you get me to straighten out my leg and dorsiflex my ankle, okay? And then you go, does that hurt your hamstring? And I go, ouch, that hurts my hamstring. It's like, well, why would that hurt my hamstring? Right? Obviously, it's not changing the length of the hamstring muscle, okay, but it is changing the length of the sciatic nerve. Right? So if this makes my hamstring pain worse, well, it's probably not coming from the muscle. It's probably coming from the sciatic nerve being irritated at some point along its length. Does that make sense?
It does.
Yep. And so this is something that Marie and others with sciatic pain can do, okay, is if you picture this position here with the slump and the knee extended and the hip flexed and the ankle dorsiflexed and the head flexed, okay, that's the maximum tensioned position of the sciatic nerve. Well, as I bend my knee here, imagine the sciatic nerve goes slack, okay, and I'm pulling the sciatic nerve up towards my head. Okay? And if I bend my head back and lift the leg, I'm pulling the nerve down to the foot. I'm kind of sliding it up. Now I'm sliding it down. Can you picture that nerve being pulled forwards, like the head pulling the nerve, literally, the axon's being pulled up along the spinal canal. And now the leg extending, the head going back, the axon's being pulled down along the spinal canal. Can you picture that?
Yeah. But would you ever say to someone to avoid, if they had sciatic nerve pain, to avoid like repetitively getting in that position?
So just the general thing that I would say to people with chronic pain is just avoid things that aggravate it. Not because that's going to make it worse or do damage, it's just because it's not fun when you've got pain. And so, like if Marie said, like doing the rollover, it feels bad, I wouldn't say, oh, we should do more rollovers. I'd say, okay, if you can live without doing the rollover for a few months, let's give it a miss, or do it with your knees bent. Okay. But if you want to, sometimes, like we said, if that nerve is trapped somewhere, like maybe there's a disc bulge pressing on it and it can't slide past the disc bulge well, right, and that's why it hurts, because it's not sliding, it's trapped, okay? Well, if you do this movement, what I showed you a moment ago, it's called flossing. And you're literally moving the nerve back and forth, just like you do with dental floss. You're pulling it back and forth through the whole length of your body from the head to the foot. That can help to free it up, right? And so that can reduce pain in some people who have sciatic pain that is related to the nerve being trapped at some point along that pathway. So flossing is one thing I would definitely try for Marie. Not guaranteed, but it can help. It can help significantly for some people.
Thank you.
Good question.
Can I do a follow-up question for this one? When you talk about the nerve being trapped, is this a real thing with the piriformis? Because the butt, the pain in the butt is the worst. Like my leg is sort of fine, but in my buttocks, this is where the pain is the worst. Is this the piriformis kind of being?
Well, we're gonna look at piriformis. It's called piriformis syndrome, where it's because the sciatic nerve exits through L3-4, L4-5, and L5-S1. Okay, those three. It's the three-part nerve that comes out, and then those three nerve roots join together into one bigger nerve called the sciatic nerve tract, and that goes down through your butt, and it goes past the piriformis muscle in your butt, and in about 10% of people, it actually goes through the middle of the piriformis muscle, and then it goes down the back of your leg and down to the side of your foot. And so there's this diagnosis called piriformis syndrome, where it's thought that the piriformis muscle irritates the sciatic nerve where it passes through the piriformis, right? So the piriformis muscle can kind of cause irritation. It rubs, basically. And then, so the diagnosis is there. Well, it's basically the same symptoms, right, as sciatica, because it's the same nerve that's being irritated. And it's, thought to be aggravated by things that shorten or stretch the piriformis muscle. So doing clams, probably not great. And also doing like glute stretches, like this type of thing. But there's a study on this we're going to look at in a couple of weeks, I think, or maybe even next week, that piriformis syndrome, disc bulge, and just radicular pain have the same symptoms, the same causes, and same natural history. So it's like, well, we can't really tell them. It's like kind of a meaning. It's a distinction without a difference. And so it may be related to your piriformis, or it may be related to a disc, or it may be both or neither. But anyway, it doesn't really matter. The prognosis is the same. The exercise recommendations are the same. And the exercise recommendations are, get moving, try not to worry about it. If when we talk about personalising and individualising program, It would simply be based on symptoms, right? So we would use some of our physiological understanding to think about some things. So we would try flossing, right, for the reasons that we discussed. Now, it's not guaranteed it's going to work, but it's definitely worth trying. We're going to try directional preference, okay? Because if you think about the neural foramen, okay? If you think about that nerve root, okay, and you think about maybe a disc bulge here pressing into the neural foramen and reducing the amount of space that that nerve root has, okay, and that's maybe where the nerve's being irritated. Well, as we flex the spine, look what happens to the foramen. It gets bigger, okay? And as we extend the spine, the foramen gets smaller, right? So typically, not always, but typically, spinal flexion, when it's not accompanied by hip flexion, knee extension, dorsiflexion, and cervical flexion, okay, when you're not just tensioning out the whole sciatic nerve like we said a moment ago, but when you just flex your low back a bit, often alleviates leg pain symptoms in the short term for people because it gives more space in that neural foramen, all right? So we could use some of that and we could try that and see if that helped. And it doesn't always, okay, but we'd definitely give it a go. We would also try spinal extension, right? If spinal flexion made it worse, we might try spinal extension. And because there are some other mechanisms in there, like maybe inflammation, okay, and extension might sort of squeeze out the fluid out of the spinal canal and reduce the pressure in there. So we would try a bunch of those different movements. We would try some glute stretches. Okay, we would try just some general mobilisation of the low back, some rotation, some cat-cows, some hip movements and stuff. And we would see if any of that helped more than anything else. We'd try some heat. Okay, we'd try some belly breathing. We'd just keep trying stuff until we found what worked. Okay, and we probably wouldn't find something that would be a 10 out of 10 perfect solution, but we'd probably find some combination of things that would give some significant amount of relief in the short term. And those would be Marie's little kind of emergency first aid, things to do when she needs some pain relief. Might be like, 2 stretches plus some flossing, or hot water bottle plus this particular stretch, or whatever it might be. We'd just have to experiment and see what works. And aside from that, it would just be like, we'll just get moving and do whatever you can do and let symptoms be your guide as to if you pull up well the next day, that's fine, you can keep doing that thing. Okay. If you don't feel great the next day after doing it, do less of it or do a lighter version of it or avoid it for now. Does that all make sense?
Thank you so much. That helps. Okay.
Michelle Selden, do you still have a question?
It's more or less a comment. Well, it is a comment. And by the way, Marie, there were 2 comments made about the injections by Sarah Gibbs and Alyssa for you. I don't know if you've had the chance to read those, but they were helped by the injections. Yeah, cool. Just to let you know too, I did have sciatica many years ago, and mine was from a nerve impingement, like where I lifted a filing cabinet by myself. I was being ridiculous trying to move house, and then I moved sideways and basically caused the impingement. And my karate teacher had an inversion machine, and I hung upside down in that, and he actually just did some manual movement of the nerve and just got it out. So that he also said to me I was dehydrated and I increased my fluid intake. So yeah, I don't know. It could be something as simple as being in an inversion machine and drinking more water. So, but I have to say, with the inversion machines, they don't work if you've got a leg length discrepancy, if one leg's longer than the other, because you'll be hanging more by one leg than by the other. So it wouldn't work then. So, and the best way you can check that is if you're lying on your tummy and someone looks at your knee creases and then matches it up with your ankles and sees if it's coming from there. But it can also come from the femur area, from the quads and hamstrings, from that area as well. So just make sure your legs don't have different lengths. Otherwise, you could be doing more damage. So that was it was meant to be a brief comment, but yeah, just that.
Anybody else got anything you want to share or ask about? Judith.
Yeah, I'm trying to consolidate all this in my head for a second. So basically for lower back and sciatica, there's nothing you can do. The good thing is it's gonna go away. If you're in pain at that moment, it's gonna not be that great, because this is what I feel like most people, they feel like shit at that moment. Obviously, it's not great to be in pain, and the perspective is really bad. And what happens after, and I see this in my own clients, they have like this fear going, like it's gonna come back, or it's gonna shoot something or something like that. And the only thing you can do about it is see if there's any personal preferences that might alleviate it temporarily. Do I get that correctly? Is that a good sum up? Ish.
I would give it a more optimistic spin, and I would say, rather than there's nothing you could do, I would say like almost everything's going to help to some extent, and that definitely movement is good. And the movement, which particular movement should be determined by the person's preference, what helps their symptoms, and it's going to be different for each person, and what they can tolerate. That mental and psychosocial well-being is very, very important. And you can have the exact same disc bulge and the exact same pressure on a nerve root, one in two people, and one of them is completely pain-free and one of them bedridden.
Still be different.
Yeah, and that can be because of a bunch of other things like stress, sleep, beliefs, physical activity, social support, other factors. And so, yeah, it's true to say that there's no exercise that's going to impact the disc bulge or the disc degeneration or the whatever, right, in there. But we can impact these other factors, psychosocial factors. So general movement is going to reduce inflammation. Right, is going to improve sleep, is going to improve psychosocial health, etc. And we can see like a sleep doctor, and we can improve our diet, and we can spend meaningful time with loved ones, and we can do all of these things that feed us, and we can reassure our clients and help them develop more optimistic narratives and stories about why it hurts. Right, so an understanding about the cup of resilience, or the cake metaphor, or whatever you want to use. And all of these things, and we've got our symptom reduction techniques, self-massage, breathing, heat, stretching, isometrics. We talked about flossing. We're going to talk about directional preference in a couple of weeks. Now all of those symptom reduction techniques combined, for some people, magic, right? Bit of a tennis ball, rub it on your butt, pain's gone, amazing. Now it comes back 4 hours later and I have to do it again, right? But great. 10 minutes every 4 hours, I'm pain-free. Fantastic. Amazing. Other people, massaging and stretching for an hour, hot water bottle, dropped it from a 6 out of 10 to a 4.5 out of 10, right? There's no silver bullet for some people, and it's just a matter of you've got to gradually improve those, multiple things over time, the psychosocial health, the stress, okay? And it's going to pass. And you've just got to keep them focused and optimistic enough to not give up, because what often happens is people, they do everything. They do all their stretches and their core activation, and they get to bed on time. They do all these things, and then 6 weeks later, it still really, 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 really hurts. And they think, well, what's the point? I might as well just do nothing, have a glass of wine, and lie on the couch and cry. And
it's it's when you're in the thick of it, that's the hardest bit, to convince them into that positive mindset, because you're in pain at that moment. It's like it's like screw it, at that point. So I find that part quite hard, because I getting through it with most people and moving, and that also helps. I get that same experience. But when they're in the thick of it, it's like when nothing seems to help and it stays the same, like, then what?
Right. And, you know, we certainly don't have a perfect answer, 3 million studies in. But as we know, pain is an unpleasant sensory and an emotional experience, okay? And so we've talked a bunch about altering the sensory component, okay? We sometimes have limited success with that. We can do a lot towards altering the emotional component though. And, again, a kind of cup half full way of interpreting, well, nothing makes a difference is like, well, great. Nothing makes it worse. I can do everything I could normally do, right? I've just got this pain all the time, right? I can deadlift. I can go bike riding. I can, swim. I can play with my kids. Can't do the rollover, okay, right now. But all of these other things that are meaningful to me, I can still do them and they don't make it worse, right? They don't make it better either. So what we can do is encourage people to re-engage with those things that are important to them, okay, that don't significantly aggravate their symptoms, or give them a strategy to engage with those things in a different or reduced way that doesn't aggravate their symptoms. So if Marie loves deadlifting and that's super important to her, rather than saying, okay, well, just don't deadlift for the next 12 months, right? Well, that's a horrible existence for her if she loves deadlifting. So, okay, well, how can you deadlift, through this, right? Does that mean we do like fewer sessions or shorter sessions or less reps or less weight or less range of motion, okay? Or can we just do your normal sessions and will you just be totally fine? Won't make it better, won't make it worse, right? So the ideal is she just keeps deadlifting. But if we need to adjust some of those other parameters so that she can keep deadlifting, or mountain biking or swimming or playing with her kids or playing softball or walking with her girlfriends or whatever it is that she loves doing, right? How can we keep her engaging with those things? Because often it's the fact that people can't do those things that is the most important to them.
I think what you said there really hit the light bulb for me, because I have in the past I had a couple people who were in pain and we were doing all the things as prescribed here. And it's just like they felt debilitated by that pain and they wouldn't want to do those things that they would usually do. And then you go into that negative spiral, as you said, because then there's no good outlook, positive outcome, no social, no nothing. So it makes personality is such a huge influence. I can definitely tell. And what I saw is also like in these cases, if the medical personnel assisting them was saying like, don't do X, like fear mongering kind of thing, like don't do X, Y, Z, that really make the difference on their outcome, I suppose.
Yeah.
Thanks.
Yeah, no worries. And also, I did, there's a great, I did a great podcast interview with a sleep physician, actually, happens to be Debbie's husband. Recently, that's coming out in the next week or two. And one of the things we talked about, I talked about with Russell, who's the sleep physician, is that, we've talked a lot in this course about, sleep being important for recovery and resilience and stuff. But there's kind of a paradox with sleep, is that the more you obsess about getting a good night's sleep, actually the harder it can be to get to sleep, right? So if I've got my blue light blocking glasses on and my room's perfectly, dark and cool, and I'm lying there and it's 7 p.m. and I'm like, go to sleep, go to sleep, go to sleep, go to sleep. It's like that can paradoxically make it really hard to get to sleep, right? So, and it can be the same. So getting to sleep is this thing is like the less you try, the easier it is, sort of thing. And so it is with pain sometimes, right? So if Marie's got this like 90-minute routine that she has to do of stretches and self-release and breathing techniques and activations and foam rolling, in order to function, right, or in order to, fix her sciatica or whatever, it's like, basically she's focusing on the pain like all the time, right, and she's thinking, I've got to get rid of this pain, I've got to get rid of this pain, I've got to do all of the things. It's like, well, actually what you want to do is actually not think about the pain and not think about your back and just get on with your life, right? Because like if you've ever, I mean, you've all had like a headache or a toothache or a neck ache or a backache at some point, right? And then you realized when it goes away, what's so great is you just don't think about it, right? You just eat and you don't think about your tooth. Like that's what it means when your tooth works well, is you never think about it, right? And the same thing with your back is when your back's just working, you're not aware of it really from 1 minute to the next. It just does its thing. And so paradoxically, when we have pain and we focus on like all of the muscles we've got to activate and the stretches and the routines that we've got to do, it can actually, we become hyper vigilant on that body part, right? So paradoxically, maybe another approach that we might take with Marie, right, is say, hey, throw out all of the stretches and the flossing and the directional preference and the muscle activation and the foam rolling and all of that stuff. Let's just go do some deadlifts, right? Fuck it. That's what you like doing. Just do that, okay? And then just go and watch some telly with your daughter and, get to bed, right? Like, so we would just try different approaches because each person's different, okay? And you just have to sort of, partly through dialogue with the person and partly through just a little bit of gut feeling, partly through trial and error, just find what particular combination works for that person best. Anything else? Or are we done? Okay. Great convo, team. Really nice to see all of you. Hope you have a wonderful week. And I'll see you in Slack.